Boy, with 5 minutes, I think I know what speed dating feels like now. First, let me say that none of my slides cite drug addiction as one of the barriers researchers will face in assessing treatment as prevention in this population, people who inject drugs, for two reasons. One, it's obvious that addiction can be both a cause and consequence of life circumstances that make treatment adherence difficult. But the other point is that I don't want to play into the idea that injection drug users cannot change their behaviors to lower their risk or to maintain health practices. And I'd like to go back 20 years, more than 20 years, and cite an example from Chicago in our own work, in which we observed an HIV incidence of almost 10 per 100 person years that quickly declined to 75% and stabilized in the face of a network-oriented, peer-delivered, continuous street-based intervention. This was at a time when the federal government wouldn't even pay for bleach. So I think, injection behaviors, we shouldn't forget, are more amenable to change than risk behaviors. And that will vary by in a social context they occur, of course. One reason I think treatment as prevention is so important for injection drug users now is that ones who have been exposed to interventions and have reduced their behavior, in our own experience and others that I've read, generally see themselves at low risk for HIV infection and don't realize that network circumstances, the background HIV prevalence and as such conspire to infect them. The other reason, of course, is there are environments where behavior change is very difficult. So first slide. Oh, me. I thought this was a high-level conference, and I didn't. There's a mismatch between HIV rates and IDU populations and availability of HAART, which Rich Needle covered yesterday. Countries with high levels of HIV prevalence and incidence driven by injection drug use may have substantial shortfalls in the availability of medications. In Russia, it's estimated that there's a shortfall of about 1/3. In Ukraine, it was reported in 2009 that only 7% of those receiving ART were IDUs. And these countries account for most HIV cases in Central and Eastern Europe. There's mismatches between OST availability and HIV rates in IDU populations. There's an absence of methadone and buprenorphine treatment that undermines adherence. We know that methadone and buprenorphine treatment support adherence to ART by illicit opioid users, but it's often unavailable or insufficient in countries with high levels of HIV prevalence and incidence driven by people who inject opioids. Stigma and highly punitive approaches to drug use impede successful ART. In countries where HIV is driven by injection drug use, people often fear that disclosing that they're HIV positive is tantamount to disclosing that they're also an injection drug user. This can cause problems with police, family, and even medical providers. And adherence may be particularly difficult when family support is crucial for adherence. And these policies and situations create barriers to harm reduction interventions that could promote, seek, test, treat, and retain research. A fourth problem that researchers may face in assessing treatment as prevention is that some populations are highly mobile and difficult to follow. Migrant workers would be one, and in the CDC study in the 1990s in New York City, they recruited young injection drug users and had a very difficult time following them because they traveled city to city across the U.S. And while Desjardins and colleagues turned that lemon into lemonade and developed an intervention that was good at dealing with this problem, documenting adherence and outcomes would have remained difficult in that population. There's sort of an inter-system mobility of IDUs as they move between providers in the community, criminal justice systems, medical care systems, mental health hospitals, drug treatment programs, and other systems, which would make it difficult to access records regarding adherence to ART and its outcomes as a study participant moves across these systems. And in some countries, accessing medical records other than those created by the researcher may pose ethical problems. And finally, their socioeconomic issues and policing often greatly restrict the mobility of IDs. So for many people who inject drugs, ART needs to be provided in or very near the neighborhoods in which they live, regardless of the quality of treatment that may be offered elsewhere. I should say, regardless of a higher level of treatment that's offered elsewhere. So researchers need to be mindful about what accessibility to ART means from the point of view of potential study participants.